This child has been coughing for the past 2 weeks, increasing in severity. No significant fever. The child is comfortable without any dyspnea in the intercough period. There is a past history of asthma, but the child is not on any medication for asthma as of now. Some 2 weeks before the onset of child's symptoms, the father had some cough, not at all significant to take any medication. Now see this video clip. Okay, the first OSCE question is what is the diagnosis? It is very obvious, it is whooping cough. So why it is whooping cough? What are the positive points? One is paroxysmal cough of many days that exhausts the child. Second is post-tussive vomiting. Third is whoop that you have already listened to in the video clip. Contact with a probable case, that is true basically because the father has had a cough that was mild, but whooping cough in an adult is always mild because they have got bigger airways, so it will not get blocked by the sticky secretion, and the cough will be like any other ordinary cough. Only thing is they will give the disease to the baby or a child. Immunization status of the child must be inquired into, which was not done in the history, and that is a lapse. Now, no significant fever in the 2 weeks of illness. That means child occasionally required paracetamol, but it was not a significant fever, and not dyspneic in between paroxysms. Now, what are the differential diagnoses? One is asthma. The child is a known case, but the important point here is if it is an asthma, in between cough episodes also the child will be dyspneic. Here the child is more or less comfortable. Second thing is the viral pneumonia, where again we do not expect the child to be free of dyspnea in between cough episodes, and more than that, a 2-week pneumonia without significant fever, even if it is viral, is a little unlikely. And foreign body aspiration, we do not have a history of choking suggestive foreign body aspiration. The next OSCE question is, what is the striking finding in the complete blood count of whooping cough? The answer is total count is quite high, and more important, the lymphocyte count is very high, maybe up to 70 to 80%. The difference of lymphocytosis in whooping cough from that of a viral infection is, in whooping cough the lymphocyte is of normal morphology, whereas in viral infection it is likely to be atypical. Now the other 2 points actually are not answer of this question, but still I will mention it because it's important and can form a question. Under the national program, all suspected whooping cough cases should be reported to the surveillance team. And in national surveillance, nasopharyngeal swab is taken within 1 month of cough onset, and it should be in a designated media. The media that we use now is Regan-Lowy media, and if IgG is sent, it should be between 2 and 12 weeks of onset of cough. Next question is, what are the complications of whooping cough? They come under 3 headings: mechanical, pulmonary and CNS. Mechanical would be like, because of the severity of the cough, you can have subconjunctival hemorrhage, involuntary passage of urine or feces during cough, prolapse of rectum, especially in the malnourished child, and worsening of hernia if it is already there, or a new hernia that is appearing. Injury to frenulum of tongue is also very common in whooping cough, and you can have a look at the video clip again now. See, the tongue is actually protruded to the limit, causing repeated rubbing of tongue to the lower tooth, causing injury. Now, what are the pulmonary complications? One is apnea, that is in small infants. Why is it so? Cough is a forceful expiratory process. You go on coughing, and the brain detects, or the respiratory center detects hypoxia and orders inspiration, but you are in the process of expiration. So in that situation, if you want to start inspiration, you need a lot of power. which a small infant is lacking, and so instead of taking an inspiration, they go in for a apnea.
A bigger child will take forceful inspiration even though glottis is not fully open, and thus the whoop is produced.
Then pneumonia, especially later on, the pneumonia is always a secondary bacterial infection, and in whooping cough, the secretion is very sticky, and the child is trying to dislodge it by effort of coughing. And because of this sticky secretion, the air may be let in but not let out, so that may cause obstructive emphysema, or it will be a total obstruction, so distal air gets absorbed, so that leads on to atelectasis. And we can have a transient bronchiectasis, which means the elasticity of the airways are lost temporarily, which will come back after some time. And CNS complications, one is anoxic seizure. That is basically because you go on coughing and you don't take inspiration frequent enough, and hence you go on for anoxia. Or encephalopathy, and many of these encephalopathies show a punctate bleed in the brain. Now, what is the management? Macrolides is the mainstay of management as far as antibiotic is concerned, and 40 milligram of erythromycin per kilogram per day for 14 days. This will stop transmission of disease, but it can reduce the intensity of cough only if it is started very early in the course of disease. Otherwise, it will prevent transmission but possibly may not reduce the intensity of cough. Now, second is the feeding instruction. Feeding is likely to be retained if the feed is given immediately after a vomiting, because during vomiting it will dislodge the sticky secretion, and for some more time there will be no more sticky secretion, and you are less likely to cough.
A sudden thrust of diaphragm will even dislodge a foreign body, as in Heimlich maneuver. So it's not surprising that blocking plugs can get dislodged with diaphragmatic movement of vomiting.
And if the cough is going on, then you give IV fluid and maintain the hydration. Humidification of air is another important thing, because I said it is a sticky secretion, so if there is enough moisture, then it will become less sticky. Oxygen as is needed, and avoid triggers of cough. For example, laughing, deep inspiration, throat examination, all these things will stimulate another bout of cough. Now, the treatments that we use in clinical practice are of doubtful value and possibly better not mentioned in examination. Examples would be salbutamol, cough suppressants, steroids, sedatives, and so on. Thank you.